Hey everyone, so this is the Chapter 41 Assisting in Geriatrics lecture. So we start with talking about the physical changes of aging that happen to our patients as they get a little bit on the older side. We're going to start with the changes to the integumentary system. So the older population has thin and wrinkling skin. Sometimes you'll see on our older patients that their skin almost looks a little bit translucent. You can see veins and vasculature underneath it is very thin and tears very easy. Sometimes also older people will have something called liver spots, and those happen as melanocytes gather in common locations, so they'll get them on their arms, on their hands, sometimes on their face, so you'll see those too. Changes to the nervous system include slower reaction times and thought processing, decreased blood flow to the brain from arteriosclerosis, shortened attention spans, and difficulty multitasking, which is caused by a decreased frontal lobe size and shrinkage of the temporal lobes, which then leads to weaker signals in the brain for processing. Also, fine motor activities decrease and memory loss is oftentimes noted. And then lastly, for the nervous system, vision and hearing acuity, along with taste and smell senses also decrease. For the musculoskeletal system, changes here result in osteoporosis, which is decreased bone density, and osteoarthritis or degenerative joint disease as well. Cardiovascular changes include decreased cardiac output, arteriosclerosis, postural hypotension, which is where the blood pressure drops when a person goes from lying to sitting up or sitting down to standing. Increased risk of heart disease is also a factor for the geriatric population. Respiratory changes include loss of lung elasticity. Intercostal cartilage starts to calcify, curvature of the spine happens, and that is called kyphosis, which is humpback. You'll notice that a lot of the older population starts to have a little bit of a humpback. That kyphosis, or the humpback, makes it hard for the lungs to expand fully, and that results in an increase in the shortness of breath. In the genitourinary system, symptoms include a decreased kidney function and loss of bladder control. In the immune system, geriatric population is susceptible to infectious and autoimmune diseases such as cancer and rheumatoid arthritis. The digestive system, they will see increased constipation caused by a lack of exercise and poor diet. Also sometimes fecal incontinence from a lack of muscle tone, so they may have some times where they lose their bowels more often. In the endocrine system, decreased thyroid function and loss of estrogen in women, and decreased thyroid function is for both genders, and then loss of estrogen in women and decreased aldosterone, which is the hormone that regulates blood pressure, in both genders as well. For the psycho-emotional changes, some things that can affect the psycho-emotional well-being of the geriatric population include major life changes such as retirement, spousal and friends and family deaths. Those can all lead to depression or withdrawal for an older person, so it's important to monitor them and to watch our elderly patients to provide them with resources, to educate their family and their caretakers on what to look for signs of depression and withdrawal. Socially, elderly populations may find an increased spirituality. They do prefer routines. Some of them stay in their homes even when they're older and elect not to move into like assisted living. Some of them become snowbirds, where they go to a warmer climate for like 6 months out of the year during the winter, and then come back home to their long-term home in the warmer months. And then lastly, a lot of times grandparents will find that they have closer relationships with their grandkids than their actual children, and the grandkids, their relationships with their grandkids are highly valuable to them, and they help to keep them younger and help to keep them active. So that's good. For page 2, diseases and disorders of geriatrics, we have Alzheimer's disease, which is a severely debilitating progressive brain disorder. It causes changes in personality, mood, and behavior, causes memory loss, and a decreased ability to perform tasks. With Alzheimer's, the cure is, there is no cure for Alzheimer's, but we can, the patient can take medications to slow the progression. So unfortunately, Alzheimer's is progressive. There is no cure. However, some medications are available to slow down how quickly that disease progresses. Osteoarthritis and arthritis, those are chronic inflammations of joint tissues. Symptoms include pain, swelling, and stiffness in joints. Treatment is usually anti-inflammatory medications, and at times it could eventually lead to a joint replacement surgery. Cancer is an abnormal growth of cells that invade other tissues. They may need surgery, chemo, or radiation, or a combination of any of those. Side effects of the treatment options are bigger concerns for geriatric patients because it is harder on them than it is on a younger person. For cardiovascular disease, abnormal heart rates, coronary artery disease, valve disease, and congestive heart failure are all pretty common diseases and disorders for geriatric patients. Medications, surgery, lifestyle changes, and diet changes are used to treat those cardiac diseases. Cataracts also are an issue for our aging population. That is where the lens of the eye becomes cloudy and opaque, and it causes a decreased vision and ability to discern colors, so they can't really differentiate between the different colors. Sunglasses can help with this, but eventually they're going to need surgery to replace the lens itself. Hypertension is a common concern for an aging population. That is a blood pressure over 140/90. It is often accompanied by no symptoms, so it's asymptomatic. Treatment often includes dietary changes, exercise, and medications. Constipation and diarrhea cycle is a common occurrence for our aging population as well. It is constipation followed by diarrhea that occurs when the diet lacks fiber and liquids. And so what happens here is that patients will use laxatives and anti-diarrhea medications to treat either the constipation or the diarrhea, and so they will overuse those two types of medications, and that just ends up perpetuating the condition, and so it becomes this constant cycle of constipation, diarrhea, constipation, diarrhea. Diabetes mellitus type 2 is type 2 diabetes that is diagnosed by high levels of sugar in the blood. Symptoms include fatigue, hunger, increased thirst and urination, and blurred vision. Treatment, medications, diet, exercise, all of those things can help treat diabetes. Now, with diabetes, if you have a patient, they will probably be referred to a diabetic nutritional counselor to help learn how to eat properly to control their diabetes. So that's going to be really important. Diet and exercise are a huge factor for controlling diabetes in patients, and so medications can help, but the big thing with controlling diabetes is going to be diet and exercise. Hyperlipidemia is high cholesterol that is high fat level in the blood, can result in atherosclerosis that is different than arterial sclerosis, so make sure you know the difference between those two. That's where your med term comes in handy. Treatment includes medications, also diet and exercise comes into play there. Osteomalacia is a softening of the bones due to vitamin D and calcium deficiencies, so it makes it easier for the bones to break and fracture. in older populations. Osteoporosis is different than osteomalacia. Osteoporosis is an endocrine and metabolic disorder of the musculoskeletal system. So patients with osteoporosis will need calcium supplements and other medications to treat that. And then lastly, sleep apnea is where the patients stop breathing for several seconds while they're sleeping. They may need a CPAP machine to keep the airway open during their sleep hours. Page 3 is about assisting with geriatric care. So we provide patient education as we do with all the patients that we assist with. Patient education helps to manage or prevent health problems. Make sure that you are using good communication skills and be patient. I have to tell you that a number of times I have seen, especially my younger students, and not even so much students, but younger girls, and sometimes the younger gentlemen that I have worked with over the years in various settings, both in the hospital and in an office, that have been kind of impatient and sometimes blatantly rude to the aging population. And I gotta say this, you know, I have a soft spot for older people anyway. I feel like older people have earned their time with people's attention. I feel like they deserve to have people's undivided attention, especially when they are receiving health care. I feel like older people have paid their dues, and they have, you know, they deserve the respect that I feel should be given to them. And I feel like a lot of times the younger folks, and sometimes myself included, become easily annoyed because older folks sometimes move a little slower, sometimes a lot slower, sometimes they talk a lot slower, sometimes you have to repeat yourself 3 or 4 or 5, 6 times, sometimes because they can't hear, sometimes they have difficulty seeing, sometimes they shuffle around. And you know, when you are in a very busy office and or a hospital, and you're trying to move patients in and out and around, and you know, keep the patient volume up, and you have an older patient come in and they slow you down a little bit, it can be frustrating. But how you communicate with those patients can make a whole world of difference in their day. So a lot of our geriatric patients are lonely, and a lot of them have lost their spouses, a lot of them have lost some of their children, a lot of them have lost most of their friends, and you may very well be the only other human contact they have for that day. And if you are the only other person that they are in contact with that day, I would certainly hope that you are not the rude person to them, and let that be the only, you know, contact that they have is with a rude person. And I mean, that's just heartbreaking. They deserve better than that. All patients deserve better than that, but certainly someone who has, you know, lived their life and is now on, you know, on the back end of it. So be patient with your elderly patients, and with the geriatric population that comes into your office. They may take a little time, and they may make you work a little harder to get some answers to the questions, and to, you know, to get their vitals and to do whatever. But it's important to have those good communication skills, to repeat yourself if necessary, to speak a little louder so that they can hear you with their hearing aids, or whatever the case may be. But ultimately, to always make sure that you are being very respectful to them. Our elderly patients often are in denial or exhibit confusion. They may deny that they have an illness, or that they sometimes can overreact to a problem and act sicker than one would expect them to act for a problem. And so this happens a lot. Sometimes they will just refuse to accept the fact that they are ill, or sometimes they will believe that the problem, a small problem, is something that is, you know, incredibly substantial, and they act much sicker than they really are. So it just kind of, you know, could go one way or the other, depending on the person. They may also be confused for a number of reasons, including dementia, a head injury, depression, or the misuse of medications and/or alcohol. So all of those things could lend to some confusion. Touch, this goes back to what I was just talking about a few minutes ago. A lot of geriatric patients have a severe lack of touch, so touch is important to our geriatric population. And the lack of touch may result in depression for elderly. So simply putting your hand on their shoulder can help, turn their whole day around and can help show compassion and caring on a whole nother level for them. And so sometimes, they just need a little bit of human interaction and, just a small, simple gesture, putting your hand on their hand or putting your hand on their shoulder or, helping to hold their arm as they steady themselves when they stand up, or any small gesture can be very helpful and beneficial to them. Incontinence is another problem that they run into, and that's involuntary urine leakage. It can be embarrassing for elderly, and it's embarrassing for anyone. Anytime you pee your pants a little, it's embarrassing for anyone. And it can result in dehydration if they drink less fluids to try to control it. And so once they realize that their bladder is weakening and that they pee a little every time they sneeze or cough or, stand up or whatever it is, if they drink less fluid to try to prevent that, then they can become dehydrated very quickly. So that's an issue. Preventive medicine. So elderly who grew up only getting medical care if there was a problem may not seek measures to prevent illness. So it's really important that we educate our elderly population on the importance of preventative care. So on the importance of having mammograms, on the importance of controlling their diet to control the diabetes, on the importance of having colonoscopies and PSAs and all of these things. So this is the thing, a lot of today's elderly population grew up, like my grandparents grew up at the tail end of the Depression, and so they don't, for the longest time, they would not see a doctor unless there was, they were certain they were going to die. And in fact, my grandmother is a 2-time breast cancer survivor, and she is diabetic, and she, has had heart disease and all of these things, and still getting her to go to the doctor now, today, I mean, I have to threaten to fly home and drive her sometimes to get her to go. And I'm like, Grandma, you should definitely go to the doctor to get that looked at. And she's like, I'm okay. I'm on my deathbed, but I'm okay. So, one time I had to have my mother go, and threaten to have an ambulance come and take her before she would go to the hospital. She ended up in the hospital for 12 days after. But I mean, it took literally threatening to call an ambulance, which she knew Medicare would not cover. That's what it took to get her to go. And so, a lot of the elderly population have this mentality that they don't go unless, like, something is seriously wrong because it's expensive and, whatever the case may be. So preventative medicine, they also feel the same way about, it's expensive. We don't go to the doctor unless we have to. So we don't have to go have that mammogram done, or we don't have to go have that colonoscopy done, because that's preventative and we don't need that right now. I mean, we don't need to pay for that. So it's our job, to, along with the providers, make sure that we are providing them with the education to show that, if you have that mammogram done, then it will help us catch cancer earlier, or help us prevent breast cancer from coming, which would prevent you from a further health crisis. Non-compliance with medications, those are a big deal with our geriatric populations. They oftentimes are on many medications, which makes it kind of hard for them to keep track of them. So if we can set up reminders for them, or set up pill boxes for them, medication lists, or whatever we can do, set up a method or a plan for them to help maintain medication compliance, that will help keep them on the right dosages and schedule for their medications. Also, too, this is another big deal. Medications are super expensive, and most of the aging population is on Medicare. So once they hit like 65, they go on Medicare, and they realize that Medicare only covers some of their prescription costs. And so now a lot of the major drug manufacturers have these financial assistance programs that are available to help with the costs. But I can tell you, it is quite sad the costs that a lot of our geriatric population are trying to deal with. So, for example, my grandmother, that time that she ended up being in the hospital for 12 days. I went to the hospital and to visit with her shortly after she was admitted, and the doctor came in and he asked what medication she was on, and I knew that she should have been on this cancer medication because she was in remission from breast cancer, and when you're in remission, she needed to be on this cancer medication for 5 years. Well, she was 3 years in remission, and so I knew that she needed to be on this particular medication. Well, at the time, this was before the Affordable Care Act, or Obamacare, was in place, and so Medicare had this thing called a donut hole, where it would cover a portion of the patient's prescriptions for a number of months out of the year, and then the patient would, not a number of months, it would cover a portion of the patient's prescription up to a certain amount, like the first $3,000 or whatever it was, and then the patient had to cover the next $5,000 worth of medication expenses, and then Medicare would go back and cover the next $3,000 or whatever it was of medication expenses. And so it so happened that when she was in the hospital, she happened to be in her Medicare donut hole. And so her tamoxifen for her cancer medication was incredibly expensive. It was like, I think it ended up being something like $60 a pill, and she was supposed to take one a day. And so she was very concerned about making sure that she did not develop breast cancer again, and so it took all of their fixed income to purchase her tamoxifen, her cancer medication, and so they purchased that, and because they had purchased her cancer medication, she was rationing all of her other medications. So her cholesterol medication, her nitroglycerin for her angina, and she was rationing her hypertension medication. She was rationing all of her other cardiac medications. So all of her other maintenance medications that were and she was rationing her diabetic medications. So all of her other maintenance medications that were controlling all of her other conditions outside of her cancer, she was taking those medications instead of daily or twice daily as she was prescribed to take them. She was taking them every other day, or half doses every day, or she was taking them every 3 days. And so depending on which medication it was. And so when the doctor came in there, he was like, do you take this medication? Do you take this medication? Do you take this medication? He's going through her med list, and she's just sitting there. And she's like, well, yes, sometimes. And finally I asked her, I said, what do you mean sometimes, Grandma? I mean, how do you sometimes take your cholesterol pills? How do you sometimes take your blood pressure medications? Because her blood pressure was, through the roof and all these things when she was admitted. And she was like, well, I can't afford it past my cancer medicine, and so I take it every other day, or I take it every 3 days. I can only get it filled once every 3 months instead of every month like I'm supposed to. So it was so sad, and it made me heartbroken to know that that's what she had been doing. And so thankfully, with the help of the hospital and the drug company that made the cancer medication, we were able to get her on a patient assistance program and get some financial assistance for a year with her cancer medication to help pay for part of the cancer medication while she's in the donut hole months. And then even more thankfully, later on, the Affordable Care Act came and got rid of the Medicare donut hole. So But that happens. It happens a lot with patients. They can't afford their medications when they get older. They're on these fixed incomes from Medicare. And, when they only have $4,000 a month to live on and, 1,000 of it is for their is for their house, and then they have to pay out insurance and they have to pay out for medications, and then they still have to eat and, do other things with. So it doesn't leave people a whole lot of money left to survive on. So there's that to think about when you are considering patient education for this population as well. Urine specimens, bladder muscles weaken with age, so leaks happen a lot. Nocturia is the frequent need to urinate at night. And then in females, something called prolapse happens, and that is where the uterus sags down into the vaginal canal. So the uterus starts to sag with age, and then it droops down into the vaginal canal, and that sometimes can cause incontinence or urinary retention as well. In regards to blood draws, again, the elderly have thinner skin, so the draws can be a little bit harder because it's easy to tear their skin with a needle, and so you want to be really careful. Also, elderly tend to have a little bit more delicate veins, and so it's really easy, oh, sorry about the ding, it's really easy to blow their veins. In addition to all of that, they have decreased circulation, so if you do get a good draw on them without tearing their skin and blowing their vein, it may take a little bit longer for the blood to come out. So you want to be careful too, because elderly people bruise really easy, and also too, a lot of times elderly are on blood thinners because of their cardiac issues, and so that when a patient is on blood thinners, they are going to bleed forever after the blood's drawn, so you want to make sure that you hold that bandage on or that gauze on tight to help eliminate a hematoma or help prevent a hematoma or a big bruise, because they will spread out and be big and purple and nasty looking, especially under that real thin skin. Hot and cold therapies, elderly have a decreased ability to tolerate temperature changes, so you want to make sure if you're using any hot and cold therapy on an elderly person, you want to observe for adverse reactions when using those. As far as nutrition goes, the elderly populations may have obstacles to eating, like missing teeth, or an inability to chew from jaw issues, or difficulty swallowing. They also need, so those are some things that can affect their nutrition. They need a high protein, low fat diet. They also need less calories than a middle-aged adult. A lot of times elderly people will have some barriers to access to food access. Typically those barriers involve a lack of money or a lack of transportation. So even if they have the money, they may not have transportation to get to the store. And so those may be areas where they need a little bit of help in coordinating resources. Lastly, immunizations for geriatrics include flu and pneumonia vaccinations annually, and then also a shingles vaccination is recommended for this population as well. Last page of our geriatrics lecture. Special concerns for this population include depression. Depression is very common in elderly patients, but the symptoms are often attributed to something else, and so depression is missed frequently in geriatric populations. So it's important to note and to keep asking when patients come in to a little bit deeper probe in the history and developing the chief complaint, just to make sure that we're not missing anything. Fall prevention. Falls can occur at any age, but they have much more serious consequences in the elderly, up to and including death. The elderly are more likely to fall due to poor vision, slow reflexes, positional hypotension, and also equilibrium problems. So safety measures are very important to prevent falls, because we don't want any broken bones, we don't want anybody to die from falling, and it takes a long time for an elderly person to recover from a fall because of the severity of the effect of a fall on an elderly person. So if you are around an elderly person, make sure that you are taking double care to prevent falls. Elder abuse is difficult detect. The signs of neglect can be similar to signs of chronic condition. So, it's not uncommon for elderly people to have bruises and things like that. And so sometimes those are signs of chronic conditions, and so it's easy for neglect to be missed sometimes. So it's important to, again, alert the provider if you suspect that an elderly patient has been abused or neglected, so that the provider can ask the appropriate questions. Elders can be abused physically, sexually, or psychologically, and unfortunately, if you Google news articles, you will see that this happens far more frequently than you would think. It's so sad. The elderly population can also be neglected, abandoned, or exploited materially or financially. And that happens probably far more often than you would think also. So elderly populations are exploited for their personal belongings or exploited for money all the time. In fact, the IRS is constantly putting out disclaimers, and the state, here in California, there was just one not very long ago where it was said, I think it was ABC7 maybe in the Bay Area, put out a news commercial thing or a news article on their website saying that there was a scam targeting the elderly population where, and this is an age-old scam, this scam has been going around forever, but where people will call elderly people and say that their grandchild has been hurt or abducted and they need to send money right away, and so these elderly people will end up being scammed out of money. And then there's another one where people will go around and offer to do services on elderly people's homes, and then the people will pay them, the elderly people will pay them, and then the people never come back to do the services, or they do one service out of 10 promised services or something. Anyway, there's all these scams that target elderly people because elderly people tend to be more financially secure, and they are over-trusting sometimes, or easily confused, and or can be easily confused, and that's sad. Timeshare people are horrible about abusing the confusion of elderly people as well, and so I know that to be fact. I had to get a lawyer to get my grandpa, who has dementia, out of a $56,000 timeshare deal last year. So things happen, and people are horrible for abusing elders in such a way, but it happens. So the other thing is that some elders also at times self-abuse to some degree, so just be mindful and watch for that as well. And then last but not least in this lecture, we talk about polypharmacy. Those are the effects of taking many medications at the same time, and that can result in drug toxicity, adverse reactions, and lack of the desired effect of the pharmaceutical. So when you take a whole bunch of meds at the same time, the chemicals from the medications can build up. It can cause all these adverse reactions, and then actually it can counteract the desired effect of the medications that were taken. So it's important that medication schedules are carefully established and followed, so that they only take medications that will work well together and not create toxicity or cancel one another out. So that's important to educate them on. Alright, so that's it for this geriatrics lecture. If you have questions for me, let me know, and otherwise I will see you in class.